Hello, my name is Clare. I'm Chief Exec of the National Rheumatoid Arthritis Society, NRAS. Um, we've just heard that the National Institute for Health and Care Excellence have made the final guidance of allowing access to those living with active rheumatoid arthritis that is considered moderate to have access to some of the biologics and advanced therapies. That up till now have been only available to those with severe rheumatoid arthritis. Joining me here today is Professor Peter Taylor, our Chief Medical Advisor, and who has worked tirelessly with NRAS over the past 3 years to campaign to get this change. So you're very welcome, Peter.
Thank
Tell
you.
me, what from a clinician's point of view do you feel that this change to the NICE guidance will make to you and your fellow rheumatologists across England and Wales?
Well, thank you, Claire. I think it's absolutely welcome news that after more than a decade, we now have access to some of the anti-TNFs for patients with moderate disease. Of course, as long as they actually have an indication for that, it won't be suitable necessarily for everybody, because we always have to think about the benefits as well as the risks. But what this really will mean from a patient perspective, I think, is that the quality of life will be better from day to day for those patients who can access these drugs. And over the long term, the outlook in terms of preservation of function and better ability to enjoy aspects of everyday living will be hugely enhanced. So there'll be preservation of good health over time. And the implications, of course, for the healthcare professionals are that we're going to see patients who are happier, who have a better quality of life, better function, and I hope in many ways fewer complications. As always, we have to bear in mind that every drug that we prescribe has the potential for benefit and usually a much smaller potential for harm. But where we think about the potential for benefit, it not only impacts how you feel on a day-to-day basis, but some of these benefits are actually preventative in terms of the potential complications of living with rheumatoid arthritis, which include not only advancing disability or struggling to cope with your day-to-day work, but also various other issues that can be associated with inflammation. And that might, for example, include heart disease. So we know that anti-TNFs are actually preventative and keep people in good health. So I think it will certainly involve a lot of work and labor for the workforce to identify the right people and ensure they get onto the right treatment. But the consequence of all this is that we will see a slowly increasing general health of this particular population of patients. And that, of course, is ultimately rewarding for us as healthcare professionals.
Which, of course, then will in the long run, you hope, mean that. Sorry, I've started that one again. I'll start with the workforce one. So recently published BSR, the British Society for Rheumatology's report on workforce, has been quite damning. It looks like rheumatology is in crisis. So, and that on top of recovering from the pandemic, I think just really to set people's expectations, this is not something that's going to happen overnight. And how do you think that will be rolled out over the next year, 5 years, maybe even longer?
Thank you, Claire. Well, you've raised some very important points. And I think the first point to say is just how lucky we are in this country to have wonderful rheumatologists, specialist nurses, and other members of the multidisciplinary team. So many really fine people who are working as hard as they can for the benefit of our patients. So I think that's the first and most important thing to emphasize. But it's also absolutely true that as a profession, we are up against it. And this is true in medicine as a whole. So per capita of people with rheumatological disease or even the general population, the number of rheumatologists is relatively low in the United Kingdom compared to many other countries. We are fortunate in having a specialist nurse population, and not all our neighbours in Europe are lucky to have that. But this is a major issue. And of course, we're busy training up youngsters who are coming into rheumatology. And I'm pleased to say there's no shortage of very good people. So on the one hand, we have a workforce of very good people, but far too few good people to really enable us to do what ideally we would like to do. So there needs to be investment in the specialty. Whether or not that happens, who knows? We'll have to wait and see. But I think with respect to this news about an increasing access of biologic drugs to patients with moderate disease activity, obviously that means we need to ascertain which patients might potentially benefit. There need to be discussions with these patients to initiate them on drug. And this is all happening at a time when there are enormous backlogs in work because of the coronavirus pandemic. We're absolutely not through the pandemic yet. So it is important that our patients can work with us. I think we've been very lucky in this specialty, and very much because of NRAS, I have to say, that there's been this wonderful ethos that we're all in this together. We would prefer, certainly I would prefer, not to have a sort of them and us view between our patients and the physicians, but we try to work very much together in shared decision making towards enhancing well-being and optimizing care. So what we now have is a new set of toys to play with in order to optimize care, but inadequate resources to implement that very rapidly. And for patient safety, apart from anything else, I think it's important to emphasize that it would not be appropriate to put everyone who might meet moderate disease activity criteria onto powerful drugs. For example, the disease activity scores, I'm sure our members will know, but are based on a composite measure. So it's about swollen joint counts, tender joint counts, but also blood tests, markers, and a patient global assessment of how they feel. And it's a very useful tool to guide treatment, but there will be some people who have a lot of subjective feelings of pain and fatigue, but actually they're not caused by inflammation. There are other causes. And for those particular individuals, in fact, it may be that non-pharmacological intervention is appropriate. And if you overcook them, I often use the analogy of cooking. If you undercook somebody, you run into a problem because your cake's a sloppy mess. If you overcook them, you have a burnt cake. And what we don't want to do is to overcook patients inappropriately, in which case they run into all the problems of immunosuppression. And of course, particularly in the time of a pandemic, that's even less desirable. So we have to find those patients for whom the recipe will be just right to add in an anti-TNF to their regime. There will be many such patients in the UK, and I hope all of them will be patient with us as a profession as we work our way through clinics and lists, trying to identify people and to do our best to initiate treatments where appropriate and monitor them, follow them up.
And I think that's a very great message to finish on. You know, it isn't a one size fits all. It never has been. Rheumatoid arthritis, incredibly complex disease. And that's why it is wonderful to have such an arsenal of medications or toys to play with, if you like, to treat this very diverse population. And so what we're asking is for patients to work alongside the specialist nurses and rheumatologists so that we assess the right people, get the right people onto these medications as appropriate. Peter, thank you so much for spending some time with me today to clarify where we're at, and I really appreciate it, and thank you so much for your time.